partner and continuing the commitment of scientific update and to engage you all during this COVID-19 outbreak, Intas Women Health has organized this webinar. I welcome you all to the webinar on role of ultrasound in prediction of endometrial receptivity given by Dr. Sonal Panchal. And you all are requested to put your questions through the chat box. Brief about Dr. Sonal Panchal. She is consultant sonography specialist at Dr. Nagori Institute for Infertility and IVF, Ahmedabad. Professor Dubrovnik International University, Croatia. She is Master of Ultrasound in OBGY, Ian Donald University. Faculty Ian Donald Master Courses in Ultrasound, OBGY and Master's Courses in Human Reproduction. National Academy Director, Ian Donald University. Specialized and dedicated to infertility, gynec and high-risk obstetric scans with Dopplers. More than 800 guest lectures at several state and national and international conferences. Trained more than 700 doctors of India and abroad. Director Center of Excellence for Ian Donald School, Inter-University of Medical Ultrasound. Original research work on follicular monitoring and endometrial receptivity. There are so many points to her, and she is faculty for 3D, 4D, US and US in infertility training programs in India. National Advisory Board member of International Journal of Infertility and reviewer of Journal of Human Reproduction Sciences. This is not the all. There are so many things, but I welcome ma'am for this webinar. And today we also have two eminent personality clinicians, Dr. Manal Taha from Baghdad. She is clinical infertility and assisted reproductive technology specialist, Dean of High Institute of Infertility Diagnosis and Assisted Reproductive Technology, and Professor Mohammed Saheb Al Nahyan University President. So now with this, I welcome Dr. Manal Taha to welcome Dr. Sonal Panchal.
Excuse me, there is no sounds.
We can hear you actually.
Yes, now here. Hello?
Yes, ma'am.
Hello. Hello. I would like to thank Intas company to allow us to make this meeting. According to this situation of coronavirus, there is a staying home state. Sorry, can we hear me?
Yes.
Yes, thank you. So I would like to thank Intas company and thank Professor Dr. Sonal. I'm sure we are going to hear a lot of scientific things from her. Thank you so much.
Thank you, ma'am. Thank you very much.
Thank you.
And should we start the presentation?
Yes, thank you so much. You can start?
Yes, ma'am.
Yes.
Just a second. Trying to share the screen.
Yes, okay.
Can the technical support help me, please?
Yes, ma'am. Just make it full screen, ma'am. We can see your presentation. Just make it full screen.
the presentation, but I'm okay. I cannot. I cannot move it. Yeah, okay.
Yeah, ma'am.
Is it good?
Yes, visible, ma'am.
But I cannot see my presentation because there's a Zoom screen on there.
You can minimize it, ma'am.
It's only the red thing, which probably is the cross. It is not minimizing.
So, ma'am,
I just put it on the side for a while.
yeah, sure.
Yeah,
Just,
and I'm
we
going to
can see your
continue.
presentation clearly.
Yeah, but this is not where I am going to start. Just a second. Yes. Sorry for that slight technical hitch. Good morning, all my friends in Iraq. And today I'm going to talk on the role of ultrasound in prediction of endometrial receptivity. We know that implantation has been the weakest link in the success of infertility treatment, and it is a combined function of the endometrial receptivity and the quality of the embryo and the dialogue between the two. In spite of lots of technical advances, assessment of the embryo is difficult, whether it is an intrauterine insemination or it is an IVF. So the best way to improve the implantation rates is to assess the endometrial receptivity, and the modality of choice for the same in vivo is transvaginal ultrasound. On transvaginal ultrasound, the receptivity of the endometrium can be just described routinely just in two lines, 8 to 10 millimeters thick endometrium and triple line. But this is really insufficient. One-time assessment of the endometrium does not give us a correct idea about the endometrial receptivity. Its behavior and its response to the hormonal changes needs to be studied in a normal cycle and needs to be compared with the trend in the treatment cycle. Hey, this doesn't move anymore. My presentation doesn't go ahead. Yeah. Then what are the essentials? The essentials are, we have to standardize the assessment method and reporting format of the endometrial scan. It is essential to rule out the endometrial pathologies, or if they are there, to understand what is their impact on the endometrial receptivity. And it is essential to understand the physiological changes of the endometrium. To start with, we can actually start with the transvaginal scan, with the probe introduced through the introitus into the vagina in a way so that the markers on the screen, as seen here, they always face the anterior aspect of the patient. This anterior aspect of the patient is denominated by the logo on the screen. When you put the probe inside in this way, you are seeing the uterus in the longitudinal plane. You span across from one side to the other side to find out the true mid-sagittal plane. And the entire assessment of the endometrium is to be done in the mid-sagittal plane. But before we start the assessment, it is important to angulate the probe and bring the entire endometrium into the center of the image and zoom the image adequately so that the endometrial details are well seen. What all things should we see when we are looking at the endometrium? We have to start in the mid-sagittal plane, as I've already discussed, and still we have to scroll once again across the entire endometrial width. At each point of the spanning, you have to keep a watch on the contour of the endometrium. You have to look at the central line. The smoothness of the central line is important. You should always look carefully to the endomyojunction, and you should confirm whether there are any peristalsis, and if they are there, what is the direction of the peristalsis. It is very essential that the morphology of the endometrium must be correlated with the physiological state or the time of the menstrual cycle. And if there are any pathologies, a sonohysterography is suggested. Thickness is what we always want to measure for the endometrium. And remember, once the endometrium is pulled into the center of the image, as shown earlier also and here too, you have to measure the distance from the anterior margin of the hyperechoic line outer margin to the posterior hyperechoic line outer margin, always perpendicular to the central line. This tells you the actual endometrial thickness. This is to be measured at the widest part of the endometrium. The widest part of the endometrium usually should be within a centimeter of the fundal end of the endometrium. If it is not so, if it is somewhere below, somewhere caudal, in that case, it is to be mentioned that the fundal endometrium is thinner, and the widest diameter of the endometrium is so many centimeters or so many millimeters caudal to the fundal end of the endometrium, because that tells you that the endometrium is not normal. There is something which is compressing the endometrium, or something like adhesions, which is not allowing the endometrium to grow further. If there is fluid in the endometrial cavity, we know that we would always measure the two lips separately and add the two measurements to tell the exact endometrial thickness. The fluid in between is not to be taken into measurement. Then comes assessment of the endomyal junction. That thin hypoechoic line surrounding the hyperechoic outer margin of the endometrium is the endometrio-myometrial junction. The intactness of the endometrio-myometrial junction is a very important criteria to tell about the health of the endometrium. This is because if the endomyal junction is irregular, interrupted, or not well defined, it is considered to be a sign of a poor endometrial receptivity. You can see here on this image, the entire endomyal junction in the caudal part is okay, and in the fundal part, it is being obliterated by a hyperechoic shadow, whereas here, the endomyal junction is being obliterated by a hypoechoic shadow. The obliteration, irregularity, or ill-defined endomyal junction is chiefly because of two causes. It may be because of endometritis, or it may be because of adenomyosis. You can see a thick hypoechoic area here, which is actually a distorted endomyal junction. And again, there is an irregular endomyal junction margin in the second image too. Both can be seen in endometritis or adenomyosis. Let us see how we can differentiate the two. And it's important differentiating the two because we know that the mode of management for the two is different. Endometritis can be acute or chronic. And acute endometritis is diagnosed usually only in the early proliferative phase, because it is in this phase that the endometrium is usually very thin and avascular. Instead, if it is an acute inflammation, the endometrium will become swollen, edematous, so thicken, and it also shows hyperemia, so vascularity. That means if in the early proliferative phase, you are seeing an endometrium where the endomyal junction is absolutely ill-defined or irregular, and the endometrium is isoechoic, becomes chronic. When the inflammation becomes chronic, that is when the endometrium becomes thin. It is ill-defined, it is thin, the endomyal junction is absolutely irregular, and the vascularity is decreased even in the proliferative and in the secretory phases. When talking about chronic endometritis, I'm not very sure about what is the incidence of tuberculosis in your country, but tuberculosis is one of the commonest cause for chronic endometritis in my country. And though the signs of tuberculosis are not specific for with ultrasound, But still, apart from what we saw, the thin endometrium and irregular endomyal junction, you may see micropolyposis, you may see fluid in the endometrial cavity with hyperechoic margin in the mid-proliferative phase, where usually you don't see any fluid, with absence of any blood flow in the subendometrium. You may have echogenicities and calcifications in the endomyal junction and in the endometrium. You may have an absolutely scarred endometrium or endometrial cavity, or you have a few adhesions in the endometrial cavity, which are better seen on 3D and sometimes a sonohysterography. A very typical picture, one of the probable most reliable sign to tell this is tuberculosis, is the vertical orientation of the interstitial part of the tube, which is seen on 3D ultrasound. We know that normally when we observe the endometrial cavity, it is the interstitial parts of the tubes that you see traversing on the sides. Instead, if it becomes vertical, this is because of fibrosis and contraction, and this is quite a common finding in tuberculosis. Coming to adenomyosis, typically you see interruption of the endomyo junction, as you can see here with the hyper and hyperechoic areas. You can see multiple myometrial cysts. You may see multiple hyperechoic, hypoechoic spots. You may see hyperechoic islands. And you are typically seeing here alternate hyper and hyperechoic, hypo and hyperechoic vertical bands, which is described as fan shadows. These are all typical signs of the adenomyosis. Apart from that, you may also sometimes get back turning of the endometrium in the fundal area, which is described as a ear sign or a question mark sign. And these are the B mode signs of adenomyosis. If you put on a Doppler, you would see vessels which are not arranged typically parallel like the normal myometrial and spiral vessels. You can see they are chaotically arranged in the fundal area, and they also show a larger diameter than the diameter of the normal spiral vessels. And these are the Doppler signals of adenomyosis. Coming to those abnormalities of the endometrium where the endomyal junction is intact, but still the receptivity of the endometrium is affected. And the commonest ones that we see are the polyp and the fibroids. We know that polyps are quite easy to diagnose because they are seen as echogenic round or oval structures in the endometrial cavity. They arise from the outer endometrial wall usually, and they are best seen in the pre-ovulatory phase when you have a multilayered endometrium. These polyps are usually not difficult to diagnose even on a 2D ultrasound, but it becomes difficult to differentiate the polyps from other lesions like hypoplasias, especially if they are large and they're filling up the entire endometrial cavity. And in these cases, Doppler guides us because Doppler typically shows a single feeding vessel, which is diagnostic of a polyp. If it was a hyperplasia, you may have seen multiple vessels throughout the endometrium which are regularly placed. If instead the polyp is very small, it is only the irregularity of the central line that would tell you there is a small polyp underneath. And therefore, we described the endometrium. We did mention that the observation of the central line is very, very important. Please excuse me. Sorry. The polyps are best diagnosed on the sonohysterography. Sonohysterography is a simple procedure wherein either a sonohystero cannula is used or a 6 or 8 French Foley's catheter can be used. I prefer to use a Foley's catheter. We place the balloon of the Foley's catheter in the cervical canal, and we distend the balloon with about 1 to 1.5 ml of normal saline, depending on how patulous the cervix is. This fixes the Foley's catheter in the cervical canal, And therefore, when you inject fluid into the endometrial cavity, the fluid doesn't leak out. You have to inject only maximum about 3 to 4 ml of normal saline. Please excuse me. I'm very sorry for that. So you have to distend the balloon with 1 to 1.5 ml of normal saline and just inject about 3 to 4 ml of fluid into the endometrial cavity. This distends the entire endometrial cavity, and you can see the endometrial lesions popping in the endometrial cavity. You can just take a single sweep longitudinal and a single transverse sweep on 2D ultrasound and store the 2 clips, and then study the clips frame by frame. Or you can also take a 3D volume, as you just saw in the previous picture there, which will show you not only the position of the polyp in the endometrial cavity, how much is the distortion, which wall does it arrive from, and also how much is the thickness of the pedicle, which can guide you to the mode of surgery also. The other lesion is the fibroid. The fibroids, we know they appear as hypoechoic rounded lesions, but they actually arise from the endometrium, from the myometrium. Why did I then include it into the endometrium? Because there are some fibroids which are very close to the endometrial surface, and we know that they are called subendometrial or submucous fibroids. These fibroids, when you see on 2D, they just touch the endometrium, and it's very difficult to actually find out how much is the distortion or involvement of the endometrium by this fibroid. But it is 3D, which helps you beautifully see the entire endomyoid junction pulled in along with the endometrial, along with the growth of the fibroid inside. And this tells you that this fibroid is totally endometrial, whereas there can be fibroids which are partially invading into the endometrium, and these may also affect the implantation potential. Especially talking about the totally intraendometrial fibroids, they can be easily be mistaken for a polyp. And in these cases, using a Doppler is a very good mode to diagnose, because we know that fibroids usually have a peripheral vascularity, whereas we have already discussed that the polyps have a single feeding vessel. Moreover, when there is a fibroid, because it is arising from the myometrium somewhere and it's growing inside, it will pull, it will enfold the entire endomyoid junction inside, and this is also a differentiating point. Moreover, polyps are echogenic and they are better seen in the pre-ovulatory phase, whereas fibroids are hypoechoic and they are better seen in the secretory phase. We know that whenever the polyps are submucosal, they are going to affect the implantation potential of the endometrium. But this is not always true. For example, you're seeing the fibroids here, which are truly submucous, but this doesn't come into the way of the implantation. Why? Because they are in the lower half of the cavity, whereas there are lesions, there are fibroids which are not even invading the endometrium. They are barely even touching the endometrium, but still it can affect implantation. And these are the fibroids, which are large fibroids, but they are intramural. So in that case, if we have to decide which are the fibroids that would require a surgery to improve the implantation potential of the endometrium, these are type O, type 1, and type 2 fibroids, because they distort the endometrial cavity and they also affect the vascularity of the endometrial cavity, especially those involving more than 1/3 of the total endometrial surface. And the fibroids in the upper half of the endometrial cavity, and the fibroids that are close to the cornu, because they may compress the cornu and not allow the movement of the sperm or the embryo towards the tube or from the tube. Moreover, it is type 3 or type 4 fibroids which are larger than 4 centimeters in diameter. If I'm talking about this, what are these types of endometrium, of the fibroid? How do I know which type is the fibroid? This is a palm coin or a FIGO classification, which has helped us define the position of the fibroid by the types. Type O fibroid is a fibroid which is absolutely inside the endometrial cavity and may also have a pedicle. Type 2 or type 1 is where more than 50% of the fibroid is inside the endometrial cavity. Type 2 is when less than 50% of the fibroid is inside the endometrial cavity. Type 3 is when it is intramural, but it's just touching the endometrial cavity. And type 4 is when it is purely intramural. So these two types of fibroids, if they are larger than 4 centimeter, we have to remove. Whereas these three types of fibroid, if they are in the upper half of the endometrial cavity, or they are large enough to involve more than 1/3 of the total endometrial surface, they definitely require a removal before any planning of the infertility therapy. So that is about the pathologies. Coming to understanding the physiological changes in the endometrium. We know that during the menstruation, the entire endometrium is shed off and there is blood in the endometrial cavity. That blood may appear, if fresh, as hyperechoic shadows. Clots may appear hypoechoic, and after the blood has clotted, the serum may appear absolutely anechoic. So the endometrium may have any of these appearances before the blood is completely thrown out of the endometrial cavity. Once the blood is completely thrown out of the endometrial cavity, then the endometrium appears as a single line in the early proliferative phase. And after the bleeding has stopped, it starts increasing in thickness about 1 to 2 millimeters daily during the mid-proliferative phase. As it grows, it becomes multilayered and it starts thickening under the effect of estrogen. At this stage, the endometrial peristalsis is present, and you can see the wave starting from the fundus and propagating towards the cervix. This is not to allow the sperms to travel to the tubes at this time because they are not required according to physiology. As the estrogen level rises, when it reaches equivalent to one mature follicle, that's about 100 to 150 picogram per ml. That is when the endometrium is usually grown to about 7, 8, 9 millimeters in thickness, and it becomes a multilayered endometrium with anechoic or severely hypoechoic areas in between the lines. This is called a grade B endometrium according to Smith et al. Whereas if the estrogen levels, they rise beyond 250, 300 picogram per ml, gradually echogenicity starts appearing in between the lines, and till about estrogen levels of 800, 900 picogram per ml, the endometrium may become multilayered with echogenicities in between the line, and this echogenicity is not more than that of the anterior myometrium. And this is called a grade A endometrium. You can see with grade A endometrium, the triple line pattern is nicely maintained. Whereas if there are truly supraphysiological levels of estrogen, that is when you find a grade C endometrium, which is absolutely homogeneous. So it loses its triple line pattern, and it shows the same echogenicity as the echogenicity of the myometrium. It is not hyperechoic, it is not bright white, so it is only an estrogen predominated endometrium. It is not a progesterone exposed endometrium. A very interesting thing here, endometrium does not just tell us about the estrogen levels, it also tells us about the follicular quality indirectly. Because, for example, if I have 2 or 3 follicles of 16, 17, 18 millimeters, I expect, if they are good in quality, the estrogen level to be higher. With that, I'm expecting a grade A endometrium. But instead, if I get a grade B endometrium with 2, 3, 4 follicles, which means none of these follicles are good in quality because the estrogen production is less. Whereas if I have only 1 or 2 follicles, but I still have a nice grade A endometrium, that means this follicle is truly good and I can proceed with the ovulation trigger. That means during the proliferative phase, the endometrium becomes multilayered as early as about 6-7 days of the cycle. It starts growing in thickness. It becomes grade B first. Then if the estrogen level rises, it becomes grade A, and then it becomes grade C if the estrogen level rises further. But it is very important to remember that in all those cycles where it is a mono or a bifollicular development, most of the times the ovulation occurs only after the endometrium is grade B. But in PCO patients, you are likely to get a grade A endometrium even in a natural cycle, because apart from one mature follicle, there are going to be multiple small follicles, so the cumulative estrogen is going to be high. When there is an ovulation induction done, it is more likely that you will have a grade C endometrium, or you may also have a grade C endometrium in very severe PCOS patients. At this stage, which is a pre-ovulatory stage, now you can see the direction of the peristalsis is absolutely changed. You can see that the contraction is starting from here, and you can see it propagating towards the fundus. And this is to allow the sperm transfer. Nearly the same time as the follicular vascularity, which is about the size of the follicle 10 millimeters, the spiral arteries also start developing, and they extend towards the endometrium. And this is the effect of rising estrogen levels. The endometrial and the subendometrial flow increases in the follicular phase and reaches its maximum about 3 days prior to ovulation. The endometrial vascularity, to objectively report it, not just subjectively, it has been divided into 4 zones by Applebaum et al. When the blood vessels, they reach the endomyoid junction, it is called zone 1 vascularity. When they touch the outer hyperechoic line, it is called zone 2 vascularity. When it comes to the intervening area, it is called zone 3 vascularity. And when it reaches the central line, as you can see here, it is called zone 4 vascularity. It is zone 3 and zone 4 vascularity, which is considered optimal for the implantation to occur. Moreover, these vessels must also have low resistance flow. The RI, the resistance index, should be less than 0.6. What is this resistance index and how do I calculate it? That is to be done by using a spectral Doppler. When you switch on the color Doppler, you get 2 colors, red and blue. When you switch on the power Doppler, you get a single color, orange, which is when too bright looks yellow or when too dull looks red. But when you switch on the spectral Doppler, you will get a spectrum of the flow. The flow which is spiky is the arterial flow. The flow which is flat is the venous flow. And on the arterial flow, the peak up is the peak systolic velocity, and this is the systolic phase, and that is the diastolic phase, with this being the end diastolic velocity. So this is the diastolic flow, and that is the systolic flow. What do I mean then by the low resistance? When the diastolic flow is more than 50% of the systolic flow, I would say it is a low resistance flow. Whereas if the diastolic flow is less than 1/2, especially less than 1/3 of the systolic flow, that is when I will say it is a high resistance flow. Okay, but this is still subjective. How do I calculate the RI? Actually, you don't have to calculate it. When you put into the auto calculation, that is when you can see here there is an automatic trace happening, and you would have the RI values clearly written over there. But what does it mean? RI is calculated as systolic flow, peak systolic velocity, minus end diastolic velocity divided by the peak systolic velocity. Therefore, in all those cases where the diastolic flow is good, where the flow is low resistance flow, RI is the index of choice. But in those cases where the diastolic flow is low, that means those vessels which innate have a high resistance flow like uterine artery, it is possible sometimes that the diastolic flow will reach zero. And if that reaches zero, the RI value will reach 1. Beyond that point, if the resistance increases further, the systolic flow will further start decreasing, but RI then becomes systolic minus 0 divided by systolic. So systolic divided by systolic, and it remains 1. So the increase in the resistance cannot be further compared. In these cases, we use PI, pulsatility index, as an index of resistance, and it is measured by systolic minus diastolic divided by the temporal average velocity of the entire cardiac cycle. So that is an index which we will use for the uterine, and RI is the index which we will use for the endometrium. It is this index we use for the follicle flows also. So that is about the pre-ovulatory endometrium, where the vessel should reach zone 3 and 4 and the RI should be less than 0.6. What happens after that? After that, when the surge starts, LH surge starts, that is when there is an increase in the uterine artery resistance for 48 hours, and therefore it is essential that you do not do a Doppler to evaluate the endometrial receptivity after giving a trigger. In the pre-ovulatory period, the uterine artery resistance decreases to PI of 3.2, which was higher earlier. The resistance increases as the surge starts, and then when the progesterone level starts increasing, this resistance starts decreasing. If you understand this with the hormonal changes, it is with the rise of the estrogen that the endometrial flow increases. The endometrial flow reaches peak here. Because the endometrial flow is more, the uterine artery resistance falls. Then when the ovulation occurs, there's sudden fall in the estrogen levels. Because of this estrogen fall, the endometrial vascularity is severely decreased immediately after the rupture. It is just before that that the progesterone starts rising, but it takes time to reach a plateau, 4 to 5 days, during which the uterine artery resistance starts decreasing, but it reaches its minimum only in the mid-luteal phase when the progesterone reaches a plateau. What is the effect of this progesterone on the endometrium? At the start of the progesterone exposure, the outer margin of the endometrium starts becoming fluffy. If you remember the endometrium that you saw for the pre-ovulatory scan, the grade A endometrium, it had a sharp outer margin. Instead, here the margin becomes like you have done by a highlighter, it becomes fluffy. And this fluffy endometrium is a normal finding on the day of ovum pickup or on the day of IUI. This is because of the physiological rise in the progesterone, and this is an advantage. This is a preferred sign, and it leads to a better receptivity of the endometrium. But after more than 24 hours of exposure of the endometrium to the progesterone, then the outer margin of the endometrium starts becoming hyperechoic. And if you get this endometrium before you are going to plan an IUI, it is not a good sign, because it says that the endometrium is exposed to either a longer duration of progesterone or a higher level of progesterone. As the secretory phase advances, this hyperechogenicity progresses towards the central line and close to the early luteal. So about day 5, 6 of the luteal phase, you will see an endometrium like this, and it's only in the mid-luteal phase that the entire endometrium becomes hyperechoic. So if you look at the endometrium in the luteal phase, in the early luteal phase, it becomes fluffy, then it becomes hyperechogenicity of the outer margin, hyperechogenicity increases, and in the mid-luteal phase, it becomes completely hyperechoic. Apart from the echogenicity and the morphology, the vascularity also changes. The endometrial vascularity we know is maximum in the pre-ovulatory phase. Then it suddenly decreases with the ovulation. We know the reason of that is less estrogen and progesterone both. And then the vascularity along with the echogenicity also increases, and it reaches maximum in the mid-luteal phase. The normal resistance index of the spiral vessels which are feeding the endometrium is 0.5, less than 0.5 Ri, whereas for the uterine artery, the PI in the luteal phase is less than 2.5. If you compare this with what was seen in the proliferative phase or the pre-ovulatory phase, which was 3.2, the resistance here is lower than what we saw in the pre-ovulatory phase because it's a need of physiology. It needs more blood to nourish the implanting embryo. And this work is done by progesterone. Progesterone, which is a smooth muscle relaxant, decreases the tone and the muscularis of the uterine artery, and thus it allows more flow in the uterine artery. Towards the advancing luteal phase, in a conception cycle, the velocity of the endometrial and the corpus luteal flow increases and the resistance decreases. But if it is a non-conception cycle, the resistance both in the corpus luteum as well as in the endometrium starts increasing and the velocity starts decreasing. Coming to the treatment cycle, how do I improve the conception rates? Is it preferred that it is preferred that the endometrium achieves the thickness which is most optimal for the implantation? It has a good morphology and it also has a good vascularity. Moreover, you also have to rule out possibilities of any pathologies. What is a perfect endometrium that I would expect before I give a trigger, pre-ovulatory? The thickness should be minimum 6 millimeters, preferably 8 to 10 millimeters. Morphology, I would always prefer it is A or B, but even if it is C, it is not a problem if the vascularity is good. Apart from the thickness, the dynamicity is an important sign of good endometrial receptivity. Even if the endometrium is thick, but it does not show increase in size, in thickness, it is not considered to be a good endometrium. The normal growth rate of the endometrium in the late proliferative phase should be at least 0.5 millimeters a day. Endometrial and the subendometrial vascularization may serve as a prognostic marker for ongoing pregnancy and like any other markers of endometrial receptivity. That means increased endometrial flow is required not only for implantation, it's also important for the sustenance of the pregnancy. And if it is absent, it is a strong predictor of failure of implantation in the IVF treatment, irrespective of the morphological appearances. This vascularity, which is reaching zone 3 and 4, must cover at least 5 millimeter square area because that is the minimum area required for the embryo to implant. And this is seen in various studies. The other study also says that the intraendometrial power Doppler area, if it is less than 5 millimeters square, then the pregnancy rates are extremely low. If it is difficult for us to measure that 5 millimeter square area, if we can see at least 5 vessels closely placed from both the sides, anterior and posterior, reaching the inner layers of the endometrium, it can be said that the abundance of the flow is sufficient in the endometrial cavity to allow an implantation. Zone 3 and 4 vascularity To show the importance of this in terms of conception rate and abortion rates, this study of ours is present. It shows that when the vascularity is present in zone 3 and 4, not only the conception rates are higher, the ongoing pregnancy rates are even higher, and the abortion rates are significantly lower as compared to when the blood flow is present only in zone 1 and 2. And therefore, it is essential that we always wait for the vascularity to reach zone 3 and 4 and cover at least 5 millimeter square area before we give a trigger. When the pregnancy is achieved in absence of endometrial and subendometrial flow on the day of embryo transfer, more than half of these pregnancies will finish as spontaneous miscarriage, according to another literature proof also. So, having been assessed the endometrium with Doppler and with 2D ultrasound and measuring its thickness and looking at its morphology, is anything else required? Why do we still get failures at times? That is when the role of 3D comes in. The endometrial volume nowadays is considered to be more relevant measurement of the endometrium than the endometrial thickness. And the studies have shown that when the endometrial volume is more than 2.5 ml, the chances of implantation are significantly higher. And the most favorable endometrium is considered about 3 to 6 millimeters, ml, that is cc. Apart from this, even when the blood flow to the spiral arteries show a PSP of more than 5 centimeters per second, the chances of implantation are good. Another study says no pregnancy was achieved when the volume was less than 3 FCC, and better pregnancy rates were achieved when the VI, the vascularity index, was more than 10. What is this VI? VI, FI, and VFI are 3D power Doppler indices. VI, vascularity index, tells us about the abundance of the flow. FI, flow index, tells us about the average intensity of the flow. And VFI, the vascularity flow index, tells us about the perfusion of the organ. Another study, it is calculated by taking a volume with power Doppler and then using a software which is called Vocal, which rotates the entire volume 180 degree and calculates the exact volume of the organ. After calculating the volume, a software is used which is called volume histogram, and that shows the VI, FI, and VFI values. Excuse me. I'm extremely sorry for that. Another study by Professor Kupasik and all has also shown that when the RI is low, around 0.5, and when the FI is more as compared to that values, the chances of implantation are better. That means when the average intensity of the flow is better, the implantation is better. When the vascularity index, the abundance of the flow is better, the implantation rates are better. And the third index of the perfusion, when the perfusion is better, when the VFI index is better, the prediction of pregnancy is better. And taking a cutoff of 0.24 for the VFI has a high sensitivity for prediction of pregnancy. Even in one of our studies of more than about 1,000 cases, we have shown that when the VI was more than 20, the chances of pregnancy were significantly higher, and the pregnancy rates significantly improved when the VFI was more than 5. And of course, the volume of 3 cc was minimum for our study. Though Cochrane says that vascularity of the endometrium cannot be directly correlated with the implantation rates, I don't deny the statement at all, because the implantation is a function of the endometrium and the embryo. If the embryo is very good, even if the endometrium is poor, the implantation can occur. But if the embryo is poor, an excellent endometrium is required for implantation to occur, and that is what is shown in the study. Correlation between the Doppler indices and the pregnancy outcome has been demonstrated when a non-grade 1 embryo is transferred. That means for grade 1 embryos, even if you don't check, the endometrial receptivity is fine. But if it is a grade 2 embryo, that's when it's essential. And in spite of all the tests that we do, it is not definitively possible to say it's a grade A, grade 1 or grade 2 embryo. Apart from this, it is also essential to look at the uterine artery PI. And the uterine artery PI on the day of trigger should never be more than 3.2. It has been shown in several studies that when the uterine artery PI is more than 3.2, the implantation rates are extremely low, and the ET, the embryo transfer, or the IUI should be withheld. Another study also shows that if the upper limit of cutoff for uterine artery PI is established at 3.3, the prediction of non-receptive endometrium is very, very high. Almost the specificity is almost 100%. That means, what do we want for the endometrium to be receptive? It should have a good receptivity when we see that the endometrium is about 6 millimeters minimum, preferably 8 to 10 millimeters, has vascularity in zone 3 and 4, which is covering 5 millimeter square area, has an RI of less than 0.6, and the uterine artery PI of less than 3.2. And this is minimum, I guess. We should check whether it's an ET, a frozen ET cycle, or it is a fresh ET cycle, or it is a IUI cycle. These parameters are to be checked and to be confirmed before starting progesterone for FET cycles. The present concern about the endometrial receptivity is the progesterone level and its effect before the ovulation occurs. It is known that the progesterone level always starts rising before the ovulation, and its effect on the endometrium is essential for the preovulatory preparation of the endometrium. That means progesterone always is present and should be present before the ovulation occurs. The said level or the cutoff of 1.5 nanogram per ml, which we see in the blood, I would prefer, instead of looking it in the blood, we should check the endometrium. If the endometrium shows the pathological effects of this progesterone, even if the level is lower, it is not good, because the level may be lower, but the duration of exposure of progesterone may be higher, which is seen by the hyperechoic after margin of the endometrium. And sometimes the blood levels may be higher, but still the duration may be lower, or the progesterone receptors in the endometrium are weaker, and that progesterone is not perceived by the endometrium, and the endometrium does not have the negative effect of progesterone. That means it is better to look at the endometrium, and if it appears nice and fluffy, then the progesterone levels are not to be checked. It is adequate, it is physiological, it is favorable for implantation, whereas if it is hyperechoic outer margin, this is an unfavorable endometrium. Therefore, if you're doing an IVF cycle and you're planning a transfer, this is the endometrium type that you prefer on the day of the trigger. If you're going to do a day 3 transfer, you will see the outer margin is slightly hyperechoic and slightly thickened and fluffy, but the entire endometrium is never hyperechoic. Whereas when you do a day 5, which is a blastocyst transfer, majority of more than 3/4 of the endometrium is hyperechoic, and this is a normal picture. Whereas when considering the vascularity, on the trigger day, the vascularity is maximum. Always on the day of transfer, if it is a day 3 transfer, the vascularity is going to be lower. And if it is a day 5 transfer, the vascularity has again started increasing with the increase in thickness and echogenicity of the endometrium. The menstrual cycle is a very delicately balanced orchestra of hormones and reflects as vascular changes and morphological changes in the endometrium. And therefore, Doppler studies play a very crucial role in endometrial assessment. To conclude, the B mode, Doppler, 3D ultrasound, and saline infusion sonohysterography are the modalities that help the exact endometrial assessment. And if these changes are correlated with the concurrent biochemical changes or the hormonal changes, it guides us to what is required for the improvement of the endometrial receptivity. Thank you very much. And I would invite the questions.
Thank you, ma'am, for a very insightful lecture. It was almost with all practical points, and I must say, like, it was a hands-on lecture.
Thank you, ma'am.
Yeah. So I see many questions in the comment list, and all viewers have complimented your lecture.
Thank you.
I will take few questions. They are asking, what is the meaning when we have less than 1/3 difference between systolic and diastolic flow? Does it low RI?
No. See, when what happens is that if I say that a particular vessel is a high resistance vessel, okay, so what does it mean? The muscular wall is strong. So when there is a cardiac systole, which is a gush of blood, which throws blood, that is when you will have a high velocity. But then as the heart goes into the diastole, now the passive flow is significantly lower because the vessel contracts back. That means when I have a high systolic flow, but a low diastolic flow, which means there is a high resistance, which does not allow a flow without a push. So low diastolic flow tells me it is a high resistance flow. Whereas if it is a low resistance vessel, during the systole, the blood is going to flow. But even when the heart is not pushing and is relaxing, then also the flow continues. That means there's a high diastolic flow, which tells it is a low resistance vessel.
Right, ma'am. And there is one question. What about effect of obesity on endometrial receptivity?
It is true that when the patient is obese, the follicular, the ovulatory response is poor, but the endometrial response does not significantly change, except in cases of PCO, where there is a very high androgen level. Because of the high androgen level, the uterine artery resistance also becomes higher, and that is why the endometrial receptivity may be at stake.
Right, ma'am. Does spectral Doppler measured by pulse wave?
Sorry, does?
Does spectral Doppler measured by pulse wave?
Yeah. The spectral Doppler and the pulse wave Doppler are the same. Actually, because it shows a spectrum, it can be said a spectral Doppler. There are two types of spectral Dopplers. One which is called pulse wave Doppler, which we are regularly using for our gynec and obstetric scans. The second is the continuous wave Doppler, which is used only for the adult echocardiography. So that is why I said spectral Doppler, which is a more broader term.
Right, ma'am. How can we interpret the high estrogen level in IVF undergoing patients with typical endometrial three-line appearance?
If it is a triple line endometrium, it is not truly a hyperestrogenism, because if it is a triple line endometrium, it's a grade A or grade B endometrium. But if it is truly hyperestrogenism, that's when the endometrium becomes isoechoic and homogeneous, grade C endometrium. So if we get that type of an endometrium, it's truly hyperestrogen endometrium.
Right, ma'am. Sometimes we see in the mid of stimulated cycle, the endometrium looks thick, but can't say it's triple line because of absence of myometrial line zone 2. What is that?
Myometrial line zone 2. I didn't get the question.
Myoendometrial line zone 2.
Okay, so probably you mean to say that in those cases where the endomyojunction is not very clear, how do I know what is the thickness and what is the morphology? Even if the endomyojunction is not clear, if the endometrium is healthy, if that endomyojunction is not clear because of adenomyosis, in these cases, you'll still see the normal hyperechoic outer margin of the endometrium and even the central line. So a triple line endometrium will be seen. It is true that if the endometrium becomes grade C in these cases, which is truly hyperestrogenic, that is when, because of the absence of the endomyoid junction, you cannot measure the endometrium correctly and not see the outer margins.
There are many questions. I will take only two. Do the RI and the PI have the same value to determine the vascularity?
No, as I mean, yeah, low RI means less resistance and low PI also means low resistance. But as I described, they are calculated in different ways, and therefore they may have a similar but not same significance.
There is a question. Thank you for very informative lecture. I need some re-explanation of A and B mode of endometrium and the difference.
A and B mode. We have not talked about the A mode.
Yeah.
The B mode is the mode which has
B
been,
mode.
which was the initial ultrasound, which is called an amplitude mode, and that is when we didn't get the prick pictures. We only used to get spikes. So increased spikes means a ecogenic element, and small spikes means non-echoic or less ecogenic thing, and that is called amplitude mode, which is not used. B mode is the routine 2D ultrasound that we do, and it's a brightness mode. The hyperechoic or the brighter spots indicate more dense tissues, and anechoic or less ecogenic spots indicate less dense tissues. So that's what is A mode and B mode.
Thank you, ma'am. There are many questions, but because of the time constraint, I thank you for on behalf of Intas and all the viewers and giving us very insightful lecture. Thank you, ma'am.
Thank you very much to you all.
Thank you so much, Dr. Sonal.
Thank you very much, Professor Manal.
Thank you for Intas to help us in doing this meeting. And we hope to do another meeting with you for a pleasure, for sure. And also, it is nice for us to see you in Baghdad when the condition become better than this.
Yeah, even I wish to, and it will be my pleasure.
Thank you so much.
Thank you so much.
Thank you, Dr. Manal, for giving us the opportunity to organize this webinar. And as usual, Dr. Sunil, it was a wonderful presentation, and I'm sure all the attendees must have got good insight into the subject. Thank you, Dr. Sunil Mehta, for conducting the program so well, and for the question answer session, and Janardhan for doing all logistic things. So thank you all, and we will look forward to do many more programs till we are there in lockdown. So maybe after that we'll think we can meet personally, but when we are there in lockdown, probably we would like to use this time for connecting digitally with each other. Thank you so much.
Thank you very much, sir.
Thank you. Thank you all.
Thank you, madam. Thank you. Thanks a lot.
Thank you. Bye.
Bye. Bye. Bye. Thank you.